All right, students, in this presentation, we'll be doing an introduction to physical assessment. We'll talk a little bit about the 4 examination techniques that you'll be using as a nurse to assess your patient. And then we'll talk about how to do a general survey and finish up with an integumentary assessment. You should have chapter 30 open in your Kosher book if you want to follow along. As you are learning these new skills in 102, remember to be patient with yourself. Physical assessment skills are kind of difficult and you need lots and lots of practice. And so it may be years before you feel really comfortable and proficient at these skills. So every opportunity that you have in clinical, please try to take every chance that you can to practice these skills. All right. One of your objectives, if you notice in your manual, is that you need to understand how to prepare your patient for physical assessment and also the environment. So, okay, first and foremost, of course, you're going to explain the purpose of what you're about to do to the patient. Many times, patients feel anxious or awkward undergoing physical assessment. And so, of course, you're going to reassure the patient that um, undergoing a physical assessment or physical exam is not uncomfortable and won't harm the patient. Your book goes on to discuss the importance of protecting your patient's confidentiality and also preserving your patient's dignity. At this time, you might want to take a look at the box 30-3. There are some pointers there for when you do a health assessment. As far as preparing the environment, your book recommends a well-lit room that is also warm. And then, of course, you're going to provide for privacy. Position your patient so that they are comfortable. Your book mentions that although undergoing a physical assessment is usually a painless procedure, it is important to determine beforehand whether there are any positions that cause pain to your patient or are otherwise contraindicated. And your book also talks about maybe you want to have the patient empty their bladder ahead of time because you will be um, pressing on the abdomen and also the suprapubic area, and that can be uncomfortable. And then as far as draping, you should have on hand a draw sheet or a blanket so that you can cover areas that are not being examined. Not only does this keep your patient warm, but it also avoids exposing parts of the body that the patient may feel is embarrassing to expose. And then lastly, you want to make sure that you have all of your supplies organized so that your assessment can flow and um, you don't have to run for anything and everything's in its place. So if you look at table 30-3, you can see there some typical supplies and equipment that's used for a physical assessment, and we will have these supplies ready for you when we practice in class. Not only do you have to organize your supplies, it's really important to organize yourself. So for this slide, why don't you take a look at box 30-1 on page 514 in your Kosher book. And here you'll see that they've given you a head-to-toe framework. And we'll go through each of these steps in the coming weeks in 102. Today we're going to talk about general survey and what that means, and then we'll also talk about head and neck assessment. And you can see under each of those There are some bullet points for various areas for assessment. One other thing that we're going to talk about today is assessing the integumentary system, and this refers to the patient's skin, hair, and nails. It's difficult to just do these separately. So, for example, when you are assessing a patient's cardiovascular and respiratory status or their abdominal system, you're going to be looking at the patient's thorax and their abdomen. And so that is also a good time to assess the patient's skin. Similarly, when you are doing a musculoskeletal assessment on a patient's upper or lower extremities, that is also a good opportunity to look at the patient's skin. So I just want to note to you that we always talk about doing a skin assessment, but very unusual for the nurse to just look at all the skin all at once, do that, and then move on to other body systems. Rather, we incorporate skin assessment as we're going along. There are 4 assessment techniques that the nurse uses, and the very first one is known as inspection. And when I say it's the very first one, I mean that deliberately because it is the very first technique that we put into place as we are doing our physical assessment. Rather than auscultating first or percussing or palpating, inspection is always the very first technique that we use. On page 517, your book gives a definition of inspection, which is that it is the examination technique in which the nurse uses his or her sense of sight. The nurse inspects with the naked eye, but also sometimes we use special equipment during inspection. What findings can typically be identified through this examination technique? Well, nurses will use inspection to evaluate moisture of skin, also the color and texture of body surfaces, as well as the shape, position, size, color, and symmetry of the body. Your book also mentions that other senses also fall under the category of inspection, such as olfactory and auditory. The next examination technique is known as palpation. Palpation is actually the second examination technique that is done in sequence. Remember, we said inspection is always the first that's done, and then next comes palpation. Palpation refers to the examination of the body using your sense of touch. And so we often use palpation to determine the texture, perhaps of the patient's hair, temperature of the skin, position, size, consistency, and movement of organs or masses. We also use palpation to evaluate for distension of the abdomen or the bladder. And we use palpation also to evaluate whether we are causing any tenderness or pain. There are 2 types of palpation that you'll read about in your Kosher book. The first one is known as light, and this is the type of palpation that we'll be focusing on as nursing students. Deep palpation is more of an advanced assessment technique, and it is limited to usually like a reproductive exam or maybe assessing liver size. So in your everyday work as a nurse, you'll most likely be doing light palpation. Light palpation is the use of one hand to gently apply pressure, and not just applying pressure, but you apply pressure lightly several times. And you'll see nurses often like using kind of a circular movement as they are applying pressure. And that allows the nurse to feel for any masses or any abnormalities below the skin surface. So if you look on page 518, it talks about characteristics of masses, and I hope you don't feel any when we're practicing on one another. But these are the types of things that the nurse is assessing for with palpation. Your book also gives a few other pointers for palpation. Of course, your hands should be clean and warm. But here's another tip. Areas of tenderness should be palpated last. If your patient is complaining of abdominal pain in the right lower quadrant, you should assess the other areas of the abdomen first with your palpation technique and save the next examination technique is known as percussion. And your book describes percussion as the act of striking the body surface to elicit sounds that you can actually hear or perhaps feel as a vibration. There are two types of percussion, direct and indirect. Direct is when the nurse directly strikes the area to be percussed with his or her fingers. Indirect, you can see a picture of on the top of page 519, and that involves using two hands. You can see in that picture that the nurse is percussing over the flank and is perhaps trying to percuss over a kidney. We'll practice percussion in class. It's a little bit hard to describe on a PowerPoint. However, I would like you to take a look at these definitions and where you would expect to percuss these sensations. Flatness is a dull sound produced over very dense tissue, such as muscle or bone. And so when we practice in class, we'll be asking you to percuss over a classmate's rib or perhaps a muscle. And I wonder if you'll be able to detect a sensation of flatness. Dullness is a thud-like sound produced by dense tissues such as the liver, spleen, or heart. So these are over visceral organs. Resonance is a hollow sound such as that produced by lungs filled with air. And hyperresonance is not a usual finding. And it is something that you might detect over a lung that is diseased, such as with emphysema. And then lastly, timpani. If any of you were in high school band and played the drums, you'll know what I'm talking about here. Timpani is a musical or drum-like sound produced over an air-filled stomach. So again, when we practice together, hopefully you'll be able to detect these types of vibrations or sounds when you use percussion. Our last examination technique is auscultation. And usually in our sequence of examination techniques, auscultation is the one that we do last. There is an exception to this, and this is when we do an abdominal assessment. And I won't say much about that now. We'll save that for when we actually cover that next week in class. Auscultation refers to the process of listening to sounds produced within the body. Your book gets into direct versus indirect. You can read that if you want. However, we'll be practicing auscultation with our cardiovascular, respiratory, and abdominal assessments. So I'll save the discussion on those for another time. However, you do want to read in your book about pitch, intensity, duration, and quality of the sounds that you hear upon auscultation. And those are on page 519. You've just learned 4 examination techniques. Let's use one of those techniques, inspection, to perform the very first part of a physical assessment. The first step in a physical assessment is known as the general survey. General survey involves observation of the client's general appearance, their level of comfort, their mental status, and it also includes vital signs and height and weight. So from the very moment that you introduce yourself to your patient and explain what you're about to do, you can begin performing your general survey. Through your conversation with your patient, you can immediately discern whether your patient is alert and oriented. You can also determine through conversation and also observation and inspection whether your patient is experiencing any distress. Is your patient able to answer questions without getting short of breath or experiencing pain, for example? Is your patient's speech clear? Are they making sense? Are they cooperative and able to follow commands? Some other areas of general survey include hygiene and grooming. Through your inspection, you can clearly determine whether your patient is dressed appropriately for the weather, if their clothes are clean, their hair combed, their teeth brushed, or whether they have any other problems in this regard. From the moment you take your patient back to the exam room, you can also take a look at their gait. Is their gait smooth and coordinated, or do you detect any limitations? For example, does the patient have a shuffling gait? Do they have a limp? Do they have a hard time walking down the hallway to the exam room without getting short of breath or experiencing pain? And similarly, what is the patient's posture like? Are they able to sit upright? Or are they having problems so much so that they need to lean over? Is their posture stooped, maybe because of a spinal problem? And lastly, through your conversation with the patient, through inspection and observation, what is the patient's mood like? Are they pleasant or are they withdrawn? What frame of mind is the patient in? So you can see in just a very brief introduction to your patient, getting them ready for the Following the general survey, we're going to just talk about the integumentary assessment. As I mentioned earlier, it's not always prudent or possible to simply do this as a separate assessment. As I mentioned, integumentary assessment is often integrated or incorporated into other assessments. So for example, if we are going to do a musculoskeletal assessment of the upper extremities, that's also a good time to assess the patient's skin as well as their nails. But just in general, keep in mind that an integumentary assessment usually involves two of our techniques that you've already learned. The first one is inspection, followed by palpation. There are times when you may detect a problem with open skin or perhaps a lot of perspiration. And the medical term for that is diaphoresis. And so, of course, it's your judgment whether you need to use gloves or not. Let's concentrate on using our inspection technique first. So, whenever we have a chance to look at a patient's skin or an area of their skin, the very first thing you're going to do is inspect. And so, one of the first things you should do is inspect the color of the skin. Also, take a look and try to determine whether the skin color is uniform, because there are some times where there are areas of hypopigmentation or hyperpigmentation. Also, as part of your inspection, assess for edema, and if it is indeed present, try to note the location of the edema, the degree to which the skin remains indented, and you can look at the bottom of page 526 so you get an idea of what I mean about that. And then also, another challenge for you is to inspect and also palpate any skin lesions, and I'll talk about that on the next slide. Also, if possible, assess for skin moisture. You do that through palpation. In addition to palpating for skin moisture, You should also palpate for the temperature of the skin. And you can do this using the back of your hand or the backs of your fingers. And then one last thing as far as palpation, note skin turgor. And in order to perform this, what you do is you just take a gentle pinch of skin on a patient's forearm or on their sternum, and then release. When you release that skin, the skin should spring back to its normal or previous state very quickly. In other words, the skin is very elastic. Sometimes, though, when you do this on an older adult or a person who is dehydrated, skin turgor is diminished. In other words, it takes longer for it to return to its normal position than you would expect. So just to summarize, for assessing the skin, you want to inspect the skin color, also assess for uniformity of skin color, and assess for the presence of edema. As you're doing your skin assessment, don't be surprised if you come across some skin lesions. There are many, many commonly seen skin lesions in humans, and so it's really good for you to be able to identify some of the most common ones. And that way, if you do see something that's abnormal, you will know right away that it's abnormal. So if you do know the type of lesion, of course, go ahead and document that. In addition to that, though, you may also want to document some other aspects of the lesion or lesions. And so, of course, you want to include the size of the skin lesion, the shape and texture, as well as the color. All of these may indicate a normal situation, or they may point to something more worrisome. And it's not unusual for a nurse to get on a measuring tape and to actually measure a skin lesion. Some other things that you might want to include in your assessment and then also as part of your documentation is the distribution of the skin lesions. Distribution is described according to the location of the lesions on the body, as well as the symmetry or asymmetry of findings in comparable body areas. I think what they're talking about here in your Kosher book is there are some disease conditions where the distribution of skin lesions occur in a certain pattern. And the one I'm thinking of most commonly is shingles. These kind of follow, they go along a nerve pathway, so they kind of have a linear presentation, and they only appear on one side of the body. Location, if you can describe where on the patient's body, that would be great. And use as many adjectives and descriptors as you can. You want to give a good picture with your documentation so that the next nurse can actually picture it in his or her head and that they can locate the lesion that you've just described in your charting. And then also configuration. This refers to the arrangement of lesions in relation to each other. Sometimes the configuration of lesions appears on a line, as I said with shingles. Sometimes they can appear circular, as in a condition known as tinea corporis. That's a fancy word for ringworm. Or sometimes they can be just kind of a random pattern. So if you can, I think the best thing to do is to look at some pictures. And you might want to look at page 524 as we're talking about this. So what you have here is, this is known as a macule. A macule is a flat, it's always an important word, a macule is flat, change in color on the skin. And another defining feature of a macule is that it is small. It is always less than 1 centimeter in size. So if you see a freckle, or maybe a small birthmark, sometimes a tiny bruise, that may be described as a macule. So again, a macule is flat, it's an area of discoloration, and it's small. It's less than 1 centimeter in size. This is a common finding. We've probably all had one of these. The layman's term for this is a blister. But in medicine and nursing, we refer to this lesion as a vesicle. A vesicle is a circumscribed, round or oval, translucent lesion, and it is filled either with serous fluid, which is the clear fluid, or sometimes blood. Vesicles are usually smaller than 0.5 centimeters. Now, of course, we've probably all had bigger blisters than that. If it is larger than 0.5 centimeters, we give it a different name, and that's when we call it a bulla, B-U-L-L-A-E. Vesicles and bulla are circumscribed, and that's just a fancy way of saying that they have clear margins. On this slide, and it's not the greatest picture, this is known as a keloid. This is an overgrowth of tissue after a traumatic injury. Many people, they have an injury to their skin and it heals without any major scar formation. But in some cases, there's an overgrowth of scar tissue, and that's known as a keloid. On this slide, you'll see what's known as a papule. A papule is a raised, circumscribed area of skin. When I say circumscribed, I mean that it has clear margins. Papules are always less than 1 centimeter in size. I'm sure you can recognize that this is a common wart. The other name for a wart is known as verruca, but when you do your documentation, you can also describe this as a papule. This is a very common finding that you'll see in your older patients at the nursing home. This is known as a seborrheic keratoses. Seborrheic keratoses are associated with sun damage, and they're frequently seen on the back, the chest, and especially in men, the top of the head. Seborrheic keratoses are benign. They do not turn into cancer. I would describe these lesions as being papules because they are raised and they have circumscribed margins, and they're smaller than 1 centimeter in size. Take a look for seborrheic keratoses when you go to the nursing home and you're doing a skin assessment. I have a feeling that you will. Here's another common finding that you will see on people as they get older. These are known as cherry angiomas. They commonly appear after age 40, and you'll typically see them on the patient's trunk. Again, these are not cancerous. They're just a very common finding as one ages. How would you describe these? Would you call these papules as well? On the previous slides, I showed you some very common, expected variations of skin. On this slide, here is an abnormality. This is known as a yeast infection. Yeast infections tend to crop up in areas of skin folds and also moisture. You'll see that there's a central area of redness surrounded by some outlying satellite lesions. If you see those little satellite lesions, they look like little pinpoints. That's a common presentation of a yeast infection. Yeast infections are commonly treated with a topical ointment, cream, or powder, and in severe cases may require an oral antifungal. Let's talk about inspection of the hair and also inspection and palpation of the nails on this slide. I'm looking at page 528 in your Kosher book. So inspecting the hair, it's pretty straightforward and not too involved. You may want to use gloves if you detect any rash on the scalp or if you suspect any infestation with lice. When it comes to inspecting the hair, you're going to be looking for the distribution of hair growth as well as the texture of the hair and the thickness. Your book mentions that most of the time, most of the information about the patient's hair can be obtained just through questioning the patient. And again, any variations from normal you need to document. Normal hair is evenly distributed. Hair that is normal is usually thick. Hair is usually smooth or silky and also resilient. There are some cases, though, where there is an underlying disease process that can affect the hair, and I'll actually show you some pictures of what I mean in just a minute. Moving on to the nails, you're going to be using inspection and palpation when you're assessing the nails. When we're assessing the nails, you're going to be looking at these areas on the slide, and don't forget to look at the surrounding skin. If you look on the top of page 530, there's one aspect of nail assessment that we'll discuss more in our small groups, and it's known as clubbing. When you look closely at your own nails, there's an angle of about 160 degrees between the nail bed and where it meets the finger. In some diseases, though, that angle is obliterated. It becomes flattened, or it can actually increase, and that's known as clubbing. So that's part of your inspection. The other thing you can do with the nails is known as a blanch test. You can gently press on the nail bed, and the nail bed color may turn white briefly, but it should quickly return to its normal pinkish color when the pressure is released. And by doing this, we're actually checking the patient's circulation. And somebody maybe with a peripheral circulatory disorder, their rate of return to a normal color will be prolonged. So we call that capillary refill time. And ideally it should be less than 3 seconds. Anything longer than that, we would suspect probably a problem with circulation. And again, as with everything, it's very important to document our findings. Take a look at this picture. How would you describe this patient's hair, and how would you document it? This patient may have an underlying condition known as hypothyroidism. In that condition, the hair appears thinner and is often brittle. Here's a little bit of trivia for you. There's another thing you can do when you're looking at your patient's hair, and don't forget to look at their eyebrows. Eyebrows often give subtle clues about a patient's health status. There's a condition known as hypothyroidism, we just talked about it, and one of the symptoms of hypothyroidism is that part of a patient's eyebrow may be thinner. Specifically, the outer third of the eyebrow is thinner or absent. This is actually known as Queen Anne's sign because supposedly Queen Anne of England back in the 1700s had thin eyebrows, and so it was named after her. And as I said, it's associated with hypothyroidism. If you ever see a patient with the inner part, the inner third of their eyebrow thin or missing, that is a finding that is often associated with lupus. So don't forget to look at your patient's eyebrows. Now it's time to look at some pictures of nails. Nails are really interesting. You can tell a lot about a patient's health status by looking at their nails. In this picture, You have a condition known as paronychia, and this refers to an infection of the skin surrounding a nail. This patient probably was biting or picking at their nails that caused this. Here's another abnormal nail. This is called a spoon nail, and I think your book has a name for it. I think it's called koilonychia. I'm not really sure how to pronounce it. But if you look at the nail, you'll see that it's thin, it's misshapen, and it's actually lifting off the patient's finger. And so, as I said, we call these spoon nails. And if you see this, you should wonder if your patient maybe has iron deficiency anemia. Look at this patient's nails. This is known as clubbing, and I think I referred to it in a previous slide. So again, take a look at your own nails. You should have a little divot or angle where the nail bed meets your finger. But in some conditions, that angle is gone or it's greater than 180 degrees. You'll commonly see this phenomenon with people who have long-standing lung disease, such as COPD. This is a common finding, and it happens as we get older. So take a look at your patient's nails in the nursing home. Don't be surprised if you see some longitudinal ridges across their nail beds. There's nothing you can do about it. It's just one of those things that happen as you get older. Now this is not a very nice picture. This is a picture of toenail fungus or onychomycosis. Take a look at the nails in this picture. You'll see that the nails are discolored, they're thick, they're kind of crumbly, and they're actually lifting off the patient's toes. This is a nail fungus. Very hard to treat. It takes a long time, and the medications that we do have to treat can also cause liver damage. So I hope none of you ever gets this problem. Well, I think I'm going to wrap things up now. I'm still working on the next part of Physical Assessment 1, which is assessment of the head and neck. Thank you for listening, and please, if you have any questions, don't hesitate to ask.